Good evening, or at least good evening on the East Coast of the United States. My name is Dr. Jack Krauser, and I'm very pleased to be working with colleagues from around the globe on this one-hour webinar on the subject matter of the All-on-4 concept. When I was getting ready to log on, I took a brief perusal of some of the colleagues and where they were logging in from, and we truly have a global event this evening. I have colleagues from Australia, Europe, North and South America, Asia, and Africa I've seen in the sign-in logs. I want to first start by having a brief well wish to our colleagues in the southeastern part of the United States, as well as our colleagues in Asia, where they were both hit by similar but different storms and tragedies. So we hope for speedy recovery. So about a year ago, I was working with Viva Learning, the organizer for this seminar, and it was actually right after Hurricane Irma. So I'm not going to accept another assignment because we'll have a hurricane at the same time. I was at the Perio meeting in Boston at that particular time. So keeping in line with some of the evolutions of the All-on-4 concept, I'd like to just do a brief review to get everybody up to speed, the concept of multi-unit abutments, and we'll have a few words about what are similar and what has changed with that. The edentulous arch is a group of patients that clearly can benefit by this type of a concept. My favorite treatment group are what we call the terminal dentition. These are patients that have suffered with multiple bouts of failing bridges, cracked teeth, poor endodontic results, and they're just going in an endless cycle of failing restorations, and they're seeking something that's a little bit more permanent. I will show in this presentation some tricks surgically, as well as some new, and I think right on the horizon of breakthroughs in the prosthetic materials and prosthetic considerations. I was trained at the University of Pennsylvania Dental School and then took periodontal training at Boston University, and I practiced periodontics in a traditional manner for most of my career. In the last, I'd say 3 to 5 years, I have been evolving into more of an all-on-4 clinician, where I've learned to handle the prosthetic aspects as well as the surgical aspects, and working closely with some technicians, I help to refine some of their aspects, which are now showing beautiful results, allowing us to get even more improved restorations. As you know, from a historical perspective, this is actually not a new concept. The concepts in Portugal, the Malo group, Abreu, and Nobri and his co-workers, plus several other clinicians around the world, have demonstrated that this all-on-4 treatment concept can actually yield a very good and long-lasting result. The original Malo group protocols have been in the literature now for more than 10 years for both arches. I feel that that's evidence-based for me, and I see many articles coming out showing different improvements and how to handle different aspects and add to the process. I always like to give homage to Professor Brennemark on the left, who was the true pioneer in the concept of osseointegration. He and his team pretty much catapulted the concept of implant therapy, but also brought to the discipline beautiful prospective and retrospective studies that showed that this can be documented over a long period of time. Now, there are other colleagues that I'll mention during the presentation that, of course, have contributed to implant dentistry in general. Now, the slide in the middle is a panoramic x-ray of a lady that I treated about 27 years ago. The upper case was a failing dentition. We took out the teeth. We let it heal for approximately 6 months. I put in implants as parallel as I could get, and I had them buried. After 6 more months, I opened it up. I did a second phase surgery, let that heal for approximately 2 months, and referred it to my restorative teammate, who then went about a 4 to 6 week preparation to fabricate the final case. So that case took clearly over a year, and that was the traditional method, and we were getting brilliant results for our patients. But these cases were both time-consuming and fairly expensive. About 7 or 8 years ago, I was following the work of Paulo Vallo, who is here, and I love this picture of him because he truly is a pioneer of connecting the world together. If you see the little dots, those are clinics that he's associated with around the world. And he's been both a clinician and an educator and a friend to many of us, and encouraged us to consider the concept of the All-on-4. The All-on-4 has now taken on various forms where we can consider doing additional implants, 4 or 5 as you wish, and the original data, which we'll cover in a second, showed the biomechanical results of why the 4 concept worked nicely. As I'm treating patients, there are a couple of classical articles in the literature that I always think about on every case. One was Grunder from the Swiss group. They were talking about where to position the implant in relation to the facial buccal plate. And the further away it was from the facial plate, the more predictable you would get. And if you look at the healing of this submerged case, you see a beautiful, robust buccal bone formation. That also would lead to very lovely and maintainable aesthetics, coupled with placing the implants at the proper height and depth, as well as inter-implant spacing, which you want to keep at least 3 millimeters. Sadly, we have sometimes seen patients from other clinics that come in where the implants are too close together, the papilla are often lost, there are deep implant defects, and those cases sometimes require removal. So I like to always think about this concept, keeping it away from the buccal plate as much as possible. Another article, particularly related to the terminal dentition, I call it the gap, to graft or not to graft. And Dr. Dennis Tarnow and his colleagues from New York area, they did a case report to show the proof of principle that you may place an implant in the socket, have it non-loaded, and it would actually grow bone in a 360-degree manner. What they did notice was that they did lose only about 1 millimeter of buccal to palatal dimension, and it was at the most coronal aspect of that buccal plate. I have a couple of slides from their article in the International Journal of Perio and Restorative Dentistry, and you can see how there was just some slight 1 millimeter gap closure in this area, but if you look at the histology, it shows excellent bone integration around that implant that received no graft. Now, some of the colleagues that would teach the All-on-4, 5-10 years ago, they were calling this a graft-less procedure. Now, originally I thought the graft-less concept had to do with augmentation of the edentulous ridge or sinus grafts that they were trying to avoid. But I found out early on when dealing with the terminal dentition, we were going to have these gaps to deal with. And I'll show several cases in a little while that will identify how we actually do not do grafting in these sites all the time. The most important advent in the pre-treatment realm is getting 3-dimensional radiographs either with cone beam or medical CTs. Many clinicians that I'm friendly with have their own cone beam in their practices, which is brilliant and allows for excellent case planning. Now, we learned years ago that posterior mandible typically would have a density type 3. But if you look just anterior to the point that I'm pointing at, that's a density 4. If you go right across, that's actually a density 1. So we found early on by studying different sections of the CT scans that bone density actually varies from site to site, very specific for each site, and it also varies by depth. So the more you study your cone beams, you could see and learn a lot of information from the pre-surgical aspects of the case. This is another one of my favorite articles. Joseph Kahn is a clinician in Loma Linda in California, USA, and he did a nice study where they looked at already taken cone beams at the dental school at Loma Linda University. So this did not require any additional radiography and radiation, and they just determined that the position of the anterior teeth as it related to the dimensions of the buccal and palatal plates of bone actually varied. And they gave a classification 1 to 4. Luckily, the class 1 has the greater propensity of patients. Now, why do I say that? Because when you take this tooth out, it leaves a beautiful triangular area of bone to anchor the implant in the most ideal spot. Now, some of these other sections, you have to be very, very skilled getting your implant into this area, or do ridge splitting techniques or bone spreading at the time of the drilling with densification methods. Speaking of the triangle of bone, in 1992, you could calculate how many years ago that is. It's quite a long time ago. Scott Gans, one of my closest friends in dentistry, he studied this triangular shape, and he was looking at it mainly from medical CT scans or panoramic x-rays. But with the advent of cone beam CT and implant planning software, we get very usable information to determine how much bone is actually in the various sites based on the cursor, the different tangential cross-sectional views, and you could use this concept even today. So Scott presented it in 1992. Later, in 2007, he and I collaborated. This is me, by the way, and this is Dr. Scott Gans, and we're smoking cigars at his daughter's wedding. A beautiful wedding was held, and we created a company called Kinetic Guidance, which the sole purpose is to teach and promote guided surgery and cone beam technology to our colleagues. So we've been doing that for more than 10 years. Why do we want precision in our placement? You've heard of osseointegration, biointegration. Well, this is called air integration. This is what you don't want. You don't want implants in air. You want them in bone. So here's an example of a well thought out implant, except it should have been actually placed on a tilt in this area. So the apex of that implant, if you palpate up into the vestibule, was subtissue, but it perforated through the bone. So we gave it a funny name, and we want to encourage people to avoid that with care and proper planning. Another concept that I use on every case is resonance frequency, or the ISQ. This is made by a company in Sweden called Ostel. I hope many of you heard of it, but more importantly, I hope many of you use it. Interestingly, there were, the last time I looked, more than 750 papers published on this technique. You would have thought that there'd be thousands of units in use, but it's still growing, and it's not as popular as I hope it would be. But for immediate load cases, I think it's a must, and you get an objective reading from a piece of equipment to determine implant stability, as opposed to oh, I feel it's good, or my torque insertion is good. So this is giving you a measurement that you could go back at other times and check it. So when we're doing the All-on-4 and placing the multi-unit abutment immediately, I want all of my implants to be over 64 in the measurement units. So if you do it a different way, if you multiply 65 by 4, you want to get a number like cumulative over 250 units for the 4. And if you put in more implants, you would be in a safer zone, but I don't always do it. What's brilliant with this All-on-4 concept is the so-called triangle. The triangular positioning of the distal implants, typically the distal implants, allows you to be anterior to the sinuses in the maxillary arch and anterior to the foramen and mental foramen loop in the mandible. Now, there are some odd configuration cases where we also tilt the anterior, but a classic All-on-4 case would have 2 distal tilted and 2 axial in the anterior. Now, I've actually taken post-operative CT scans and then put markers on the implants, and you could see that the trajectory of the apices of the implants actually ends in the middle of the skull towards the top of the cranium. And this allows all the forces to be dissipated in a beautiful biomechanical way. Now, we say we want triangles. This is a funny case that I found at a laboratory nearby. It had 4 implants, and they were all in a triangular. So what was interesting about this case, it ended with a single entry hole for the screws, and I believe the patient was actually restored. Now, we have upper teenage children in low 20s. We sometimes have the opportunity to take them on beautiful trips, and you can see how bored they are, because all I talk about on my travels is look at the biomechanical structures and how different buildings and sites of the world are structured with all triangular and biomechanical structures. Here's a bridge in Venice, Italy, also with that triangular shape. One of my buddies for more than 30 years, Professor John Brunsky, he's now at Stanford and also in Arizona. I met him when he was originally at RPI in New York. He did a series of both in vivo as well as in vitro studies where they put transducers to determine where the best position of the implants were. Would it be on a tilt? Did you have better strength? Would it be on a one-to-one relationship as to positioning? And he has done all this work more than 10 years ago. So he also looked at the length of cantilevers, and we follow the rules of Brunsky plus Charles English that talk about anterior-posterior relationships, and I'll share that with you in a few slides. Now, this textbook came out about a year ago. Scott Gans and Marco Rinaldi and another colleague from Italy, Angelo Mattola, came out with a beautiful book on computer-guided applications. One of the things that has become more important for me personally is the 3 classifications that they talked about. Freehand, yet using the cone beam information for diagnostic purposes. Template assisted is not a fully guided concept, and a fully guided template where there are actually holes or rings that allow you to position the implant into position properly. So I like to cite this. This is an example of the graphics of 2 different cases being planned as fully guided. Here, the guide would be in place, the drills would be done, and the implant would be placed through the template or guide. This is something more of a template assisted. Here, you get a duplicate of a final prosthesis in the form of a denture. The outer structure may be the actual final prosthesis and the new material, which we'll talk about a little bit later. And we can cut little windows in the posterior or in the anterior to see where the bone is. And we would just make a horizontal cut in these areas to determine how much bone reduction is necessary. And the same would apply for a lower case as well. This is a technique that I've been using for maybe 7 years now, and we make it in a full hard acrylic material. We score across at 15 to 18 millimeters from the incisal edge to that line. And that line is where I want to have my bone reduction. Above, we can have bone. Below, we don't want bone in the area because that would limit our restorative space. Keeping in mind, the final restoration will have tooth, gingiva, and the prosthetic frame material. So we will need the appropriate space, and 15 is a minimum, 18 is perfect as well. Excuse me. If you go back on the palatal aspect of that, you see there's a trough. As long as I position my implants and multi-unit abutments into this trough, I know that I will be in a favorable prosthetic position from the occlusal aspect. So here's an example of a ridge that's been flattened down. Here's the guide showing that we have the bone reduction up to here, and it measures what we want, works out nicely. Looking at it from the palatal view, this is one of the drills in the middle of the osteotomy, and you can see that the drilling allows us to position the implants within the trough. Now, it's not like a fully guided, but I'm going to be in a favorable prosthetic position. There was a recent Nobel Biocare Symposium in Miami in 2017. They had the little devices that give you, the audience participation. So there was a section on freehand versus guided for All-on-4. Before the lecturers began, 62% of the audience preferred total freehand, and 38% of the audience preferred guided. After the lectures, they were asked the same question, what do you prefer? And there was a change, a slight shift away from freehand to a higher shift in guided. Now, there are many reasons for that. The most important reason, in my opinion, was the surgical team showing guided had much better slides than the freehand team. Although both teams did beautiful work, that's what I think changed the audience. However, there were a very minimal number of people that participated, only 30, and the meeting had 200 or 300 people. These slides came from a lecture of an oral surgeon in Washington, D.C. area, Robert Emery, a friend of mine. He is a brilliant oral surgeon and has been working for the last several years on navigation. So together with Mike Block, another well-known oral surgeon from Louisiana State University, they studied freehand cases versus a static guide or an analog template, as well as a fully guided situation, and they looked at different measurement points. But if we focus just on angular error, freehand angular error was up to 9, almost 10 degrees. Using an analog template from a model or a static guide created, you see that it improved down to 4 degrees to 6 degrees. Then, if you look at dynamic, dynamic is no guide, it's just the use of a navigational tool, and the dynamic had 3.6 degrees. So fully guided was 2.6. So you see that fully guided and dynamic are still not 0 degrees. So we still have some accuracy and precision that comes about in our cases, but it's really more food for thought than anything else. Just put them up for you to think about. So this is a target, and you see 4 shots were done in a beautiful cluster. That would be called high precision. However, none of them were in the bullseye, so it really didn't have good accuracy, but they were precise. So that's probably the way I do my cases. I'm very precise, but I'm not accurate. That's supposed to be a joke. Okay, in this slide, I love this panoramic. Here I show the tilted implants showing 21 millimeters of bone versus 6.4, and both end at the first molar mesial aspect. Same thing on the other side. You could have a 21 versus an 8.5. This tells us that even though they're tilted, you're getting greater bone implant contact, plus you get the cross arch support. So it's a very interesting way to observe how we do that. Looking at a post-operative cross-section, you could see the tilted implant at the medial wall of the sinus, and that works out great. If I don't know where the sinus is, I'll make a little window and find it. So we routinely now do 4s, 6s, whatever we think is best. We do guided cases. You'll have a learning curve. There'll be prosthetic issues. This is a ugly, catastrophic framework fracture. So you don't want to have that, but you need to learn how to deal with these things. Here's a classical all-on-4, a classical all-on-6. These patients are getting beautiful restorations. Another all-on-6, and this one shows behind the sinus. We're able to position the implant very nicely and predictably. The multi-unit abutments typically come in 0, 17, and 30. The top of this, for many of the systems, but not all, is compatible in large part to the Nobel BioCare concept. And I actually think this is a good concept because our lab partners are able to know how to restore these without having to learn a new system. The connection varies tremendously by implant system. So whatever system you're using, you need to have a connection that's specific for that system, yet the restorative aspects can become quite similar. Many people like the open tray concept. There are many people that like the closed tray. And then you have the screws, the sleeves, the titanium cylinders, and the prosthesis gets made around these cylinders, and that little cone fits over the top of the multi-unit abutment. Our sponsor tonight is IDS Megagen. They're the first company that actually put together a multi-unit abutment kit or package, and in it is the whole set. So we have the abutment on a carrier, and this carrier is useful the way I do it, to place it in the trough, and all the parts that are necessary to do one unit of cases. So again, if I know exactly where my sinus is based on a series of extractions, I won't have to make a little window. If I do not know where I am, I'll make a small window using my sinus elevation kits. I go in here and push it back, and I can see where the membrane is. I'll also point forward to know where the medial wall of the sinus is, and this just go accordingly. In the mandible, I always will visualize and locate and use a blunt curette and probe inside the foramen to see where the medial wall is. By doing it this way, I have yet to have problems with nerves or issues that you would find in this area. So in positioning the tilted implants, we've learned that the distals should be no more than 45 and about approximately 30. This will give you the opportunity to place a multi-unit, and then it would redirect in a straight axial or occlusal dimension. So Professor Bronnemark's dream was that no patient will ever take their dentures out and put them in a jar to sleep with. No patient should sleep without their teeth. And once again, his whole dream was to treat the edentulous population. And from some of the people that signed up, many of you are from wealthier countries, others are from emerging and powerful countries, and I think that edentulalism is still a problem globally, but we're finding that it is diminishing. Now, just to show you some of the things that we used to do, 1988, I did this case. This guy died last year, so it's over 30 years. I did it with my local colleagues, Clive and Neil Bonner, and this was a classic high water design that we learn axial straight up implants and a high water for hygiene efficiency. Same prosthesis lasted for all that time. My former friend and teammate, I've lectured with him in many meetings across the world, in 1990s taught us to over-engineer the cases, a very bioengineering approach. Now these cases, as you look, are costly. Many implants, expensive prosthesis. Not every patient can afford this kind of a restoration. The All-on-4 concept is actually giving us more opportunities to treat more people based on financial ability. Now, I came in contact in 2006 with the Megagen group, and I participated in their wide diameter system. They did a global multi-center study, and I was one of the centers. And you see, some of the cases have 5 and 6 millimeter diameter implants, and this was in the early 2000s is when we were seeing wider diameters in use. This patient had wide diameter implants that I placed, and when I got my cone beam, I noticed, oh look, 2 of the implants look like they're having some problems. When you look at it from the side, that's a pretty big and bad problem, almost a fracture. So I unscrewed the prosthesis except the 2 offending implants, took them out. I asked the question, why do patients lose their teeth? Plaque. Look at this. Tons of plaque. Now, the intaglio surface of this prosthesis is actually flat. I've seen way worse than that. So this is still tricky because the patient, in this case, was not doing a good job with hygiene. So what did I have? These were Stereos external hex implants. So you see how old they are. And they were 5 or 6 millimeter, I don't recall. But the first, the middle, and the third are well integrated. And in the second and the fourth spot, that's where the failures were. So I did some grafting and some plugs. I filled up the undersurface, cleaned it up, and she then went to an all-on-3, which I felt was perfectly fine in those days because they're well integrated and she was against an upper denture. Now here's a case that was treated by a friend of mine, Ken Judy, in New York in 1994. Shortly after he treated this patient, she moved down to Florida, and I have been treating her ever since. This is the way she comes in almost at every visit. Meticulous, beautiful hygiene. And she's an all-on-3. So people joke with us, well, what do you do when you lose an all-on-4? Well, you have to do an all-on-3. So possible, or you could transition and add more implants a little bit later on. There are some prosthetic issues that happened in that case over the 20 plus years that we had her. Take a look at this case. Also very expensive, a lot of implants, a lot of grafting, a lot of tissue regeneration, provisionalization. A case like this in any country is going to cost a lot of money. The case was delivered 2.5 years later. What do we see? Metal. What do we see down here? Little recession. There are many reasons for these recessions. The design of the implants, the buccal plate, the positioning of the implants, the failure of the bone graft to remain plump and robust. So this, everybody would recognize, is Chewbacca. And I put Chewbacca in because when I see this patient on a visit, they come in and go, like Chewbacca, Dr. Krauser, I have recession here. What's going on? Now you have to be prepared on these kind of cases. What do you do to retreat it? It's not in the smile zone, but it's a very interesting clinical consideration. So what I propose to my patients now are these new hybrid restorations with beautiful materials, and we will not get papilla loss or recession because they are prosthetic materials. Charles English, as well as the Malo group, talked about the anterior posterior spread, and getting this trapezoidal shape and design gives you excellent stability for the all-on-4 concept. Here's an example as it comes back from the laboratory in the tissue model, and here's the example of the case that fits on top that prosthesis. We want the intaglio to be flat or convex. Do not have concavities because they accumulate food, debris, plaque, and it's trickier for the patient to do hygiene. With the flat surfaces, hygiene is very straightforward. Here's a post-operative cone beam of this particular patient, and you can see we got the implants anterior to the foramen, and it shows both accuracy and precision, so I have a clinically acceptable concept. Smile evaluation varies. Everybody has a different look. This lady actually was very unhappy with the final result because her buccal corridor wasn't filled up. So that is something that we can handle. Another patient, perfect buccal corridor. Here we have 3 patients. 2 of these are patients in my practice, and I do not know who this girl is. But you can see Julia. She's known throughout the world for having a tremendous, big, friendly smile. But canine, first premolar, second premolar, first molar. So even on an actress with a big, broad smile, it's really only first molar. First molar, first molar. So if you can get to first molar, you're fine. So beautiful aesthetics are possible, and there probably will not be any issues with papilla problems here, and we can offer a patient something very nice. So my next series of slides will be on the terminal dentition. This is Queen Nefertiti from the Egyptian Museum, Queen of the Nile. And you could see she had pretty advanced periodontal disease. This is a sketch of Leonardo da Vinci, one of my heroes, and you could look in some of the sketchbooks of Leonardo da Vinci, and he may have been the first person to have sketched all of the teeth in all of the mesial, distal, buccal, coronal, buccal, palatal aspects of all the teeth in his sketchbooks. And he looks at the edentulous situation, the collapsing of the face, and he wrote about it in many of his studies. So I love following Leonardo da Vinci. Now, this guy, unfortunately, is a homeless person standing around or sitting around the hotels in San Francisco. And all he does is say, hello, can I have some money? He doesn't even dance. He just says, can I have money? So that's truly a terminal dentition. Now, this patient of mine, upper denture, terminal lower teeth, cone beam shows almost no bone, but you have tremendous amount of bone in the basilar area to support the All-on-4 case. Here's how she clinically presents. A straightforward design. So we took out the teeth. We measure with a foramina, or we use our trough and template. And if I could note that my abutment is in the trough, I know that I'll be in a good prosthetic space. We also want 15 to 18 millimeters from the ridge to the incisal edge of the case. Comes back from the lab. The way we do it, we get it back the next day. We have a trapezoidal shape. This is the prosthesis, and we take it off the model. We clean it, and it goes from the cast to the mouth to the mirror. This case plopped right in, and it was beautiful. So many of my cases, they just fall into place. Some of them, we have to do some adjustments, but for the most part, they fall into place quite nicely, and the patients with the mirror, and they get a wow moment. This is the way it looks the very next day. This case is welded titanium plates with acrylic wrap. So the cases that I'm going to show now, I'm going to review the different materials that they're made of. This gal I've treated with Bert Langer from New York City for 30 years. He did 2 perio surgeries on her in New York. I did 2 on her in Florida. She's had 3 or 4 prostheses. They keep on breaking, getting loose, decay. She's just a sad state, and it became a terminal dentition. So her lip supports are pretty good. You see chipping of the porcelain. I could take this on and off. It breaks at the joint. So she was a true terminal case. We took out the teeth. We used the surgical template to score our bone reduction site. And then that's the way the platform of the bone looks. And we use the template to guide ourselves. So you notice this multi-unit abutment is too far facial. So I say no to this one. I change it by changing the angle from a 17 to maybe a 30. Same thing over here. You change it so there's enough space. I'd rather be a little bit more palatal than too far to the facial, because we want to preserve the plates of bone and we want to be in a proper prosthetic position. So some more views. She gets sutured up, then she gets her impressions, and we get the case back the next day. So here's the insertion appointment. This prosthesis are the titanium welded plates with the acrylic wraparound material, and it goes in the next day. A couple of weeks later, the sutures, I use absorbable material called glycolin, which takes a little bit longer to resorb, but it doesn't wick bacteria, and it works out quite nicely. A couple of weeks or months later, everything is falling into place, and she's getting ready to consider doing some work on the lower arch. So here's her smile, beautiful lip support. You don't see anything in the prosthesis, and she's been a happy camper. A couple of years later, you could see everything is holding its own, and for 4 years works out nicely. And again, this was the case that I had that distal to the sinus implant. This gentleman came in, his dentition, when you'll see in a minute when I took it apart, is truly terminal. So he's wearing fixed plus removable, fixed plus removable. He had good looking ridge. The x-ray showed good bone in this area. And we're going to have some destroyed teeth in this area, which we'll see here. As soon as we tap out the case, big decay at the bone level, cracked roots. So truly it's a terminal dentition, as you see the crack and fracture here. Now, I put in the implants, and that's the ISQ measuring tool, and we get a 76. So if I get above 65, I'm happy. So 76, great. Here's an example of an implant in a socket following the concept of Tarnow that maybe I don't need to graft, or I can graft. It's up to the clinician. Here's my measuring device in place, 71. So even though a portion of the facial aspect is not even in contact, the length allowed me to get a very stable reading of 71. Here's a posterior, this is on a tilt, 75. So I'm getting good readings on this gentleman. Now, this side, we were able to pick easy placements because the ridge was quite thick and plump. Now take a look over here. Years ago, I would have done a buccal augmentation or a ridge split or various combinations, but today I found a beautiful landing spot right here and a beautiful posterior landing spot, so it truly can be a graftless solution. We take the closed tray copings, suture the case up, and then it's ready for the impressions. And you see that they're quite straight up and down because of the multi-unit abutment changing the angulation. But this is the view that's most important as to positioning. I like my screw hole emergences to be palatal to the incisal edge. I want to have enough prosthetic material here so in incision, when they incise apples or types of sandwiches, they don't snap off anything. And that's the lab model, getting ready for the patient. Now, this particular patient had a history of blood thinning medications, so he did get a little bruise. But you'll see from some of my other cases, very few of the patients are bruised in the next day. Got a black eye, but it's going to get better shortly. 10 days later, no more bruising, working out nicely. Tissues are healing. So his final restoration, again, welded titanium and acrylic wrap. Several years later, he comes in for some hygiene visits, and he's a friendly guy, and all he likes to do is play golf. So how's your golf game? I shot an 84. Now, the guy's like 86, so he shot lower than his age, which if you play golf, that's a tremendous achievement. So we were all happy for him. This is a very nice fellow that came in. He had terminal on the upper and the lower, and he was referred to me from a good buddy of mine in Chicago, and the patient lived in both cities, Chicago and in Florida. And he only wanted to do the upper because that was what was bothering him in the aesthetic zone. So my analysis showed good bone sites after the extractions in our cross-sectional views. That's what his teeth looked like. So you see, that's the way he presented. Fractured teeth that were A-splinted, fractures, missing teeth, a typical view of a terminal dentition. His lower doesn't look much better, but it was more stable with that removable partial. I disassemble the case. You see the fractured teeth, decayed teeth, and we're able to remove everything. I used a CO2 laser to release the frenum in the area, just to allow for easier tissue manipulation. That's the way the teeth came out. I do my measurements, 15 to 18 millimeters to where the bone would be. I use the guide and the trough, and that's where I'm going to reduce that amount. I've reduced it, and I start my drilling. In this case, because the bone felt soft, I use the densification drills, and we use the insertion torque. Those familiar with this torque wrench, you know that that's at a pretty high level of insertion torque. And I think I have some ISQs in the full series. Now I like this slide because this is an extraction socket, but this is where I'm placing my tilted implant. I go more to the palatal, so that implant will end here, but deeper on the angle into the palatal aspect. It's a palatal to this socket. So it ends in this zone here, and it makes it a very stable implant for that patient. Again, we adjust the multi-unit abutment tops using the trough. And this case, very importantly, shows the use of an opposing arch occlusal adjustment jig, because these teeth are too high into the occlusion, and we make the upper prosthesis in an ideal occlusion. So this kind of a reduction jig allows me to file down the teeth at the time of the placement the next day. Here's the jig. The impressions, we use a double impression technique. That's the way the patient goes home with the comfort caps. I thin the palate. As a periodontist, I prefer to have thinner pocket areas than 4 or 5 millimeters of depth. Comes back from the lab the next day, screw emergence holes are in favorable positions. His prosthesis, that's the way it looks the next day, starting to heal in a nice way. Insert it. You can see the occlusal markings. Same thing. Titanium with the occlusal wrap, and he has nice lip support for his case. This gal had a full lower prosthesis done in 2 stages, the lower here and this one. And then came to see myself and a teammate, and we studied this and said, are we going to be able to make our upper to have a reasonable occlusion to this? We did some study models. We talked to our lab colleagues and said we should at least try. So we did a mock-up, and it looked good and felt good to the patient. So we said, okay, let's go ahead. Now, when her upper denture is out, you see facial collapse. It's classic. With the prosthesis in place, the mock-up, she had better lip support. Now, she's a very tricky lady. She brought in a picture of her here and here. She was truly a beautiful young lady, but she's a middle-aged woman now, and it's scary for us to have to make cases, like they were when they were in their 20s. She's also very timid, So I have to use all of my little tricks and devices to give her anesthetic. Anyway, her case worked out quite straightforwardly. Here's an example of the densification burr for soft maxillary cases. We use these burrs, place our implants. You see here, I was a little bit thin from buccal to palatal. I still had a 70, and I knew I was going to do a type of a graft. Here's a 76. So once again, we're able to get good stable implants. So I felt this one was too far facial, but I'm just going to do a little graft at the end. So I thin the palate as I typically do. I do my remeasuring. Here I used a graft product called Pent-Os Flex. It's compressed collagen and cortical bone in a sheet, and I'm able to just press it in, as you see here, under the sutures, and it forms a little plumping for that particular site. I believe it was here. Comes back from the lab, next position. Here she's final case, smiling, looking good. Now her case, we gave her something called carbon fiber. The carbon fiber I actually learned about, excuse me, in Europe, and it was only available in Canada. So we ordered some of the kits, and this material is almost as strong as the titanium material that we were previously using. So what materials did we actually use in our practice? Zirconia, PMMA, the high-performance polymers, PEEK, PEC, carbon-reinforced, Trilor, and nanoceramic. So these are some of the things that we've done. We've done denture conversions, the titanium plates, carbon fibers. Now I'm going to show you some of the new Trilor arches. This is a Trilor. A Trilor is a high-performance polymer material that must be milled by a technician using CAD/CAM technology. So the frame is milled. We love these frames because we can adjust them. They're lighter than zirconia, and the technicians seem to like working with them. Now, on top of this, you could do one of two things. You could either do a pressure acrylic composite material or mill an overstructure, and so that's a double mill, or do a Colzer or Ivoclar pressing concept at the lab. So here's an example of the Trilor underneath is typically white, and the outside here is another milled structure called Crystal Ultra, which is a nano composite that's a milled overstructure. And I could tell you that the technicians that do these cases very much need to understand what they're doing. And there are very few of them around. So if you find one of these colleagues in your practice, keep them. The beautiful thing of the Trilor is it has an inherent shock-absorbing component to it, because the modulus of elasticity is much closer to bone than zirconia. So the patients that wear this say, oh, feels so comfortable, and you don't get that clacking sound that you get with the zirconia. Now, I've only done this case type a couple of times. We call this in our practice group the K4 Implant Express, because the patient gets a true final in the same day. Now, how is that possible? Because we do planning, we have stable implants, we use our troughs and guides. The technician comes to our office while we're taking the impressions, and he's made templates for us. And once again, as long as my impression copings are within the frame of the lower prosthesis, he's able to do it. What does he do? He verifies it on the models. He takes it back to the lab, and then he retrofits the holes, then lutes the titanium cylinders to the prosthesis that was already made, and then it took 2.5 hours, and he comes back, and the case is inserted. Now, this was possible because he did it in advance. He had double mill before I even started the surgery, and then we did the pickup at the clinical surgery. So here's the patient, lowercase. This is a couple of weeks later. That's what it looks like. I wasn't sure what would happen with immediate loading with these materials, so I put in an extra implant, but it's the same all-on concept, and he's scheduled to do the upper a little bit later on. Oh, I don't have more slides. But this lady comes in, she had a similar prosthesis. There are people that walk around like that. And then she says, watch this. She plops that out of her mouth. So I finished her case, and this is the way she looks. She writes to me in Italian and English. In Italian, she tells me that she's at her 60th birthday party. She can't thank me enough for her smile. She loves it. Her coworkers love it. They say they smile all day. And here she is all dolled up at her birthday party. Now, she knows multiple languages because she's from American Airlines, excuse me, customer service at the Miami airport. So she worked out nicely. This is a couple of years later. Here she's smiling again. So that was the before. That's the after. And she's a very thrilled patient with her result. Now, this gal, believe it or not, is the wife of a physician. The physician has maybe 8 doctors in the practice. She works in the office as a financial administrator. She finally came to my team and told me, I'm so afraid of dentists. I can't believe how my teeth look. I'm embarrassed. I hardly go out. I won't go out to dinner. Can you help me? So we took some x-rays, planned the case, and you could see from her eyes how happy she became. When you see these cases finishing up, it's a beautiful thing for the patient. So here's a final case, also with the double milled technique, before and after. Now, I'm going to show a short video because we're getting close. I want you just to listen and watch how she smiles with her eyes.
When I eat, I can chew, I can bite, it feels good, it cuts well, I don't have any problems with it at all. It's really an improvement. I don't think I've ever chewed that well in my life, actually. No. And the tops, the bottoms are great, and the smile is wonderful, and I'm talking better. The talking wasn't as difficult as I thought it would be, and I love them.
And you'll be ready for your daughter's wedding?
Yes, March 10th, I'll be all set and smiling for all the pictures, which I never thought I would be again, so it's amazing.
Thank you.
And everybody said how great they look, everybody, and I'm showing them off to everybody.
Excellent. That's excellent.
So I take my patients afterwards and I give them a simple little, iPhone, Android phone video, and that's what I show in that case. And they're so happy. This is why we love doing these kind of cases. My last topic, I only have a little bit of material on because I'm not fully schooled in it, but I'm going to show you something exciting that's on the horizon that's not yet ready for prime time. Guided zygoma. These chrome guides are the brainchild of Jay Watson and his developmental team, and he works in partnership with colleagues at Rowe Laboratory, and we're now able to actually create surgical guides that allow for positioning of the implants. Now, you see there's a little catch over here. That's the sinus opening guide. Then you take that out and you switch it to a pilot guide, and then the pilot drill goes through the sinus up into the zygoma. There's another drill going in and a depth drill going in. So now we're able to actually guide it, and here's the final depth drill into the zygoma. Then we have placed the implant. We put on the prosthesis, which is a PMMA prosthesis in this case, and it's all sized and shaped prior to our procedure. You can see how long the implants are, typical of zygoma. Beautiful view here. You can see the implant through the sinus at the zygoma. Now her case, she had a top and bottom done the same day, and this is the zygoma team. Scott Gans, myself, Christian Yates, Thomas Kuhn, who's an engineer at the Rowe Lab, Hani Magoob, who's a brilliant oral surgeon, that's a surgical nurse, and that's a representative from the implant company who we believe should be part of our team. So plan A doesn't work. There are many more letters in the alphabet. Always remain cool. I think you should take this path. But if you don't know what to do, go that way. So thank you for your attention. I'm about 25 seconds over time. If you have any questions, let's go to the questions and see what we could help you with. Let me see. Okay, one of our colleagues asked a good question. If we have upper and lower with a titanium frame and the acrylic wrap, how often do you have teeth fracturing? Rarely, less than 10% of the time, because a lot of it has to do with how much quality of the acrylic wrap is done. Is it the pressure methods of the Colzer and the Ivoclar teeth, or is it just a layering of the prosthesis? So it has to do with more of a laboratory method. Another colleague asked, is the fiber really available in the U.S.? I cannot tell you where it comes from, but look it up on the internet in Canada. I know that it's available there. Okay, soft food diet, brilliant question. I want them, even before I start, to know that they're not going to be biting apples on day one. But I want them to eat all the foods that they can with smaller pieces. So we have them on soft food, and we also say if food makes a sound, when you crunch it, don't eat it for at least 3 months. And then it depends on how they're doing. I've seen out of, let's say, every 20 cases, we may have one prosthetic issue. Same question. Okay. Hey, here's a guy I went to dental school with. That's pretty funny. High impact insertion torque and bone compression relative to blood supply. It's the most brilliant question so far. There are two things that I pay attention to as a periodontist doing these surgeries. One, blood supply. Two, the prosthesis. If I keep those things in my mind all the time, I'm going to be in good shape. Now, I do different things to manipulate the soft tissue flap to try to get no pockets, try to get good apical positioning, suture it with apical suturing tacks so it's non-movable, and the periosteal support and blood supply will develop hopefully right away in the early time points. Now, the bone compression, I've seen many, many cases with the densification that worked well. I don't know if other people around the world are finding problems, but I have not. So I think the densification works well, but there is a remodeling that will take place in the osteotomy site. Robert asked me, will I be at the AAP? No, I won't. And he also said he liked the presentation. Thank you, Robert. By the way, here's my Gmail. Anybody that wants to talk to me and any more questions when we end, send me a Gmail and just say that you met me on the webinar tonight. Not every patient has enough bone. Well, I agree, but that's why we're learning and teaching and developing grafting techniques, zygoma techniques, and you can find islands of bone using the pterygoid, using the zygoma, and if a person doesn't have enough bone, you might have to put something like an implant in the middle of their palate with a little locator just to help them keep a denture in place. But you know, the majority of the patients are not really these dental cripple types. So this colleague had a new patient that was 92. He has 2 implants and then mandible. Okay, great. I've had 3 patients in my career that were over 100. So In my practice, 75-year-olds are, are children. So I'm running out of time, so I'm going to say goodbye, and I must end the meeting now.